Good morning, everyone. Presenting the disguise on behalf of Medicine 4. So, he's a Mr. H, 32-year-old male who does office work in Jharkhand, who presented to us with low back pain for 5 months, significant weight loss for 3 months, vomiting for 15 days, and fever for the past 15 days. So, he was apparently well 5 months ago. Then he developed low back pain, which was insidious in onset, gradually progressive. To the extent of disabling him and limiting him from his daily activities. And this low back pain has especially worsened over the 15 days prior to presentation to CMC. He also had a significant unintentional weight loss of around 10 kgs over the past 3 months. And the fever was high grade intermittent associated with chills. And the vomiting he had was around 3 to 4 episodes per day. It was non-bilious, non-projectile, and non-blood stained. And for the last 15 days prior to presentation, he was almost wheelchair bound because of the excruciating low back pain he had. However, there was no sensory deficits noted. There was no bladder or bowel incontinence. Past history was not a known case of diabetes or hypertension. There was no previous surgeries, no history of falls, no history of malignancy among the family members. Personal history, nil addictions. So based on the history, the syndrome we got was a chronic low back pain for 5 months with significant weight loss with vomiting and fever. So upon examination, he was ill-nourished, looking cachectic, conscious-oriented afebrile, pallor was noted. However, the vital parameters were stable. Systemic examination, central nervous system examination was GCS was 15/15. There was no sensory or motor deficits. Power bilaterally was 5/5. Reflexes were 2+. Cerebellar signs were negative. However, there was localized tenderness over the lumbar, lumbosacral, and the sacroiliac spine. Other system examinations were unremarkable. So putting it all together, is a middle-aged, immunocompetent, cachectic male with chronic disabling low backache, significant unintentional weight loss, vomiting and fever, with tenderness in the lumbar, lumbosacral, and the sacroiliac region. So we try to localize it. The anatomical localization could be to the bone, especially the vertebrae, because there was no other sensory or motor deficits noted. And the etiological classification, considering the chronic history and a significant weight loss, cachectic look with pallor. Our top differential was malignancy. However, infections, inflammatory disorders were considered down the line. Degenerative, considering his age, was out of our list. So under malignancies, we considered a metastatic carcinoma or a lymphoma, leukemia, spinal cord tumors, or multiple myeloma. Under infection, these were our differentials. And under inflammatory conditions, we considered the following differentials. So when we run through the investigations, he had a microcytic hypochromic anemia with elevated neutrophil count. Apart from that, he had a elevated alkaline phosphatase of 394 with a concomitant elevated GGT of 232. His inflammatory markers ESR, CRP are elevated, and his calcium was found to be 18.32 with a normal phosphorus and a low PTH. So with this picture, our malignancy was a top priority. So we went ahead and did a screening of the MRI spine, which showed a disseminated bone metastasis involving multiple cervical, thoracic, lumbosacral vertebra and bilateral pelvic bones, and also with the mild collapse of the multiple thoracolumbar vertebra. However, the spinal cord, roots, everything was normal. So on hunting for the primary, PET imaging was done, which showed a right lung lower lobe lesion as a primary. In the meantime, the biopsy which we had done earlier, bone marrow biopsy result has also come, which showed a metastatic adenocarcinoma with the immunoprofile favoring a lung primary. So our diagnosis was a carcinoma lung right lower lobe, with the liver as well as bone metastasis with the ECOG score of 3 and hypercalcemia due to malignancy. So the learning from this case is an approach to hypercalcemia. So this is in short the calcium homeostasis. When the extracellular ECF calcium reduces, it will be sensed by the calcium sensing receptor present in the parathyroid cells, and the PTH thereby it stimulates PTH release. So this PTH acts on the bone, causes resorption, and thereby increasing the calcium level. It also increases the tubular reabsorption of calcium in the kidneys. And the third mechanism is it also increases the production of activated vitamin D, that is calcitriol, which in turn acts on intestine and enhances calcium absorption. So by these three mechanisms, the calcium level is brought back to normal. When we look at the causes for hypercalcemia, most common being the due to excessive PTH production itself by a primary tumor in the parathyroid, either a parathyroid adenoma, rarely carcinoma. This can also happen with the condition called FHH, which is familial hypocalciuric hypercalcemia. In this condition, there is a alteration in the calcium sensing receptor, and so there will be increased PTH. There will be hypercalcemia, and the other causes hypercalcemia of malignancy, which could be due to PTH related peptide, which is produced by mainly solid tumors. This PTH related peptide is almost similar to PTH. The initial 13 amino acids were similar in both the PTH and PTH related peptide. So this PTH related peptide acts the same as PTH. It binds to the PTH receptor and causes all these effects. And the lytic skeletal metastasis could also cause hypercalcemia, and other common other causes include granulomatous disorders like sarcoid tuberculosis and excessive calcium intake as in milk alkali syndrome. So the clinical manifestation of hypercalcemia, it almost involves all systems of the body, starting from the CNS. The patient may present with confusion, fatigue, and in CVS bradycardia, shortening of the QT interval. It also affects the renal, the concentrating capacity of the tubules, thereby it can cause polyuria, polydipsia, and patient can present with nephrolithiasis. And GI symptoms include peptic ulcer disease and bone pain, osteopenia, osteoporosis. So these are the clinical manifestations. So first up, before approaching hypercalcemia, we must always correct it with the albumin level, because we know that 50% of the total calcium is ionized and the rest is bound to albumin. So the corrected calcium is given by the formula 0.8 into measured calcium plus 4 minus serum albumin. So hypercalcemia is when the total corrected calcium is more than 10. Mild hypercalcemia between 10 to 12, moderate is 12 to 14, anything more than 14 is severe hypercalcemia. So this will be the approach. So whenever a patient comes with a hypercalcemia, and if the patient is symptomatic and if the calcium level is more than 14, then immediate treatment has to begin, and simultaneously we have to work up for the etiologies. So if the patient is not symptomatic acutely, then we have to look for the causes. So our patient was symptomatic and had a severe hypercalcemia. So we began the treatment immediately. And the next step after starting the treatment would be to check the PTH levels. So if the PTH is elevated, then it is a primary hyperparathyroidism, which is the most likely cause, either due to adenoma. And there is another condition in which the PTH may be slightly elevated or even in the upper limit of normal. In that condition, we have to consider this familial hypocalciuric hypercalcemia. So so how to differentiate this both primary hyperparathyroidism and FSH? This is by the urine calcium creat ratio. So if this ratio is less than 0.01, then that is suggestive of familial hypocalciuric hypercalcemia. On the other hand, if the PTH level is either low, normal, or low, then that is when we call it as non-PTH mediated hypercalcemia. So our patient will fit into this category. If that is the case, then we have to measure the PTH related peptide 1,25 dihydroxyvitamin D and active vitamin D. Obviously, this PTH related peptide is not available in many laboratories. Even in our laboratory, we don't have this PTH related peptide. So if this PTH related peptide is positive, then that is highly suggestive of hypercalcemia due to malignancy. If not the case, then we have to check the 1,25 dihydroxyvitamin D. If that is high, then it suggests a granulomatous disorder, sarcoid or tuberculosis. If that is also negative, then 25 hydroxyvitamin D. If that is elevated, then it's due to vitamin D intoxication. If it is not the case, then we have to measure serum protein electrophoresis, serum free light chain assay and all. If that is normal, if that is abnormal, then it fits into myeloma. If it is normal, then look for other causes of hypercalcemia. So the treatment for hypercalcemia, if the patient is hypercalcemia is mild and the patient is asymptomatic, usually does not require immediate therapy. However, if it is symptomatic and the severe hypercalcemia, aggressive hydration with 4 to 6 liters of saline over the first 24 hours has to be ensured, along with the loop diuretics. And to inhibit bone resorption, calcitonin is administered subcutaneously 4 to 8 international units per kg. And however, the mainstay of treatment is bisphosphonates as zoledronate 4 mg IV given over 30 minutes. The zoledronate, the onset of action takes about 1 to 2 days for it to act. However, if the hypercalcemia is still refractory, then we go for denosumab, which is a monoclonal antibody against rank ligand, which is given at a dose of 120 mg subcut. So this was our patient's profile. So when he came, his calcium was 18.32. So after starting aggressive hydration with loop diuretics, we started on calcitonin on 22nd. So after that, there was calcium level reduced. Then again on 24th, it again went up. So this is when we gave a zoledronate. After this, we can see that there was a gradual decline in the serum calcium levels. He also had an AKI, acute kidney injury, which got resolved. So in our case, this is the cause of his hypercalcemia. So if we want to know whether it is due to overproduction of PTH or the skeletal metastasis, because in our patient, both were the possibilities. Either his hypercalcemia could be due to a PTH related peptide or the extensive skeletal metastasis, the lytic lesions he had. So if it is due to a PTH related peptide, so PTH related peptide almost acts similar to PTH. So PTH is a phosphaturic hormone. So it causes calcium, calcium will be high, whereas phosphorus will be low. However, in our patient, the calcium was high, phosphorus was the normal range, it was 4.6. So there's a high possibility of the extensive vertebral lytic lesions causing the hypercalcemia in our patient. So this is one case report from US, a patient, a 52-year-old male with 8-week history of low back pain, recent weight loss. He was initially managed with NSAIDs. However, the patient condition worsened and further imaging was found to have vertebral mets, and followed by PET imaging showed a lung adenocarcinoma. So this patient was currently under medical oncology follow-up. However, his molecular genetic testing is awaited. So once that result comes out, he will be started either on a targeted therapies, because his ECOG score was around 3 to 4. He was not fit for chemotherapy. So based on the molecular gene results, he will be started on targeted therapy. Take home points and approach to hypercalcemia, and any patient with a chronic non-mechanical low backache suspect vertebral metastasis also. Thank you.
one comment. When you're making the learning point, it will be more useful to people if you focus on something specific. When we take a large uh, section like an approach to a generalized problem, the thing that you want to focus may get lost in the entire this thing. Here, an interesting thing would have been, how would you differentiate between lytic lesions versus a PTH related peptide in a diagnosis of malignancy associated hypercalcemia. By the time you reached it, the people may have lost interest in the entire thing. Otherwise, it was a very well done presentation. But for the sake of time, and because there are four presentations before yours, it will be nicer if you focus on something specific and highlight that. Any other questions or comments? Okay. Okay, all presentations were well done, but for the clarity of the clinical localization and diagnosis, pens go to Andrew Kelly.